So, to talk us through traumatic glaucoma and overview, we have Dr. Mini Jayachandran. She is a glaucoma consultant at Amardeep Eye Hospital, Kollam.
Thank you, Dr. Kiran. The topic is traumatic glaucoma, an overview. Secondary glaucoma occurring due to various mechanisms related to eye trauma is known as traumatic glaucoma. It's often underdiagnosed due to the delayed onset and the patient forgetting trauma history. Ocular trauma incidence in India is 4.6% and it's bilateral in 0.4% cases. The risk of traumatic glaucoma is 2.6% in open angle cases and 3.3% in closed angle cases. Ocular trauma or surgery can cause infiltration of bone marrow derived monocytes into retina and neuroinflammation by upregulation of tumor necrosis factor 11(1b) and 116 mRNA within 24 hours. This is accompanied by ganglion cell apoptosis and neurodegeneration. Prompt inhibition using monoclonal antibodies protective against ganglion cell damage. Eye is protected from direct injury by lids, lashes and bony orbit, but it can be injured in different ways. Coming to Bett's classification of ocular trauma, can be either closed globe or open globe. Closed globe can be contusion or lamellar laceration. Open globe can be rupture or laceration, and laceration can be either penetrating or perforating. Each of these mechanisms of traumatic glaucoma requires a unique therapeutic approach aimed at medically or surgically treating it. Now coming to the classification, blunt trauma can be of early onset or late onset. Penetrating trauma, chemical, thermal, electric and radiation injury. Early onset glaucoma, the pathophysiology can be either trabecular meshwork disruption, hyphema, iritis or choroidal hemorrhage. Traumatic iritis, trabeculitis. The choroidal hemorrhage leads to forward displacement of lens, iris, diaphragm and angle closure glaucoma. Late onset can be due to angle recession, that's a tear between the longitudinal and circular muscles of ciliary body. Or it can be ghost cell glaucoma due to bleeding in vitreous cavity. The RBCs become spherical, rigid and clog the trabecular meshwork. Hemolytic glaucoma due to hemolysis of RBCs and hemosiderotic glaucoma due to toxic effects of iron on trabecular meshwork. Hyphema can be by two mechanisms, can cause glaucoma by two mechanisms. Trauma to globe leads to anteroposterior compression and simultaneous equatorial expansion leading to tearing of blood vessels of iris and ciliary body. Sudden rise of intraocular pressure less AC anterior chamber hyphema is 85% incidence. Rebleeds can occur 2 to 5 days after the initial bleed and the incidence is in intraocular pressure. Coming to the grading of hyphema, grade 1 is less than 1/3 of anterior chamber, grade 2 1/3 to half, grade 3 more than half, grade 4 is full anterior chamber. It's also known as 8-ball hyphema if it is dark red blood. Now angle recession glaucoma, blunt trauma forces aqueous humor laterally and posteriorly against the iris and angle. Traction on iris root causes tear between longitudinal and circular muscles of ciliary body. And the gonioscopy shows widened ciliary body band and increased visibility of scleral spur. If more than 180 degree of angle is recessed, there is more chance of glaucoma. Two peaks of onset of glaucoma, that is at 1 year and 10 years. Early glaucoma is due to trabecular meshwork disruption and ciliary body laceration. And late glaucoma is due to scarring and sclerosis of trabecular meshwork and Schlemm's canal. Then coming to lens subluxation and dislocation. Anterior dislocation of lens will cause pupillary block. Posterior dislocation can cause vitreous prolapse and pupillary block. Then phacolytic glaucoma, also trabecular meshwork obstruction by vitreous in anterior chamber. Coming to penetrating injury. Hyphema, lens dislocation, phacolytic or gaussal glaucoma. Then corneal injury causing shallow anterior chamber, peripheral anterior synecdoche and secondary angle closure. Then posterior synecdoche leading to iris bombae. Injury to lens causes inflammatory glaucoma. Epithelial downgrowth, retained iron foreign bodies cause siderotic glaucoma. Epithelial downgrowth caused by penetrating trauma or a patent fistula between external eye and anterior chamber. It leads to abnormal introduction of epithelial cells into anterior chamber and proliferation over the trabecular meshwork or angle closure due to peripheral anterior synecdoche formation. There are three forms of epithelial downgrowth: pearls, cysts and membranes. Membrane is the most aggressive form. Now coming to surgical trauma causing glaucoma. Cataract surgery, it can be due to retained viscoelastics, inflammation, hemorrhage, pigment dispersion, vitreous, peripheral anterior synecdoche or pupillary block. Glaucoma surgery can also cause raised IOP post-TRAB. Then post-PA also can cause raised IOP. Then penetrating keratoplasty, Desmet stripping, endothelial keratoplasty prosthesis, vitreoretinal surgery also can cause glaucoma post-operatively. Post-penetrating keratoplasty glaucoma can be of early or late onset. Early onset due to viscoelastic sutures or large graft and inflammation. Late onset can be steroid-induced or persistent inflammation. Malignant glaucoma can occur following cataract surgery and glaucoma surgery. In glaucoma following retinal detachment surgery can be due to mechanical narrowing of angle due to indentation by the encircling band, can be caused by silicone oil or gas injection, and steroids, ischemia causing rubeosus iridis and neovascular glaucoma. Then retinal detachment itself causes release of photoreceptor outer segments into vitreous, which clogs the trabecular meshwork, that is Schwartz-Metzger syndrome. Acid injury causes tissue coagulation. Alkali injury, tissue saponification. Glaucoma is more in alkali injuries. There is a bimodal increase in IOP. Early rise is transient due to scleral shrinkage and release of prostaglandins. Late rise due to trabecular meshwork damage, peripheral anterior synecdoche, and pupillary block due to posterior synecdoche. Then thermal injury due to hot water, hot cooking oil, fire explosion. Radiation exposure causes retinopathy and neovascular glaucoma. Electrical injury causes pigment dispersion. Periocular trauma causes caroticocavernous fistula, which can raise the episcleral venous pressure, leading to secondary glaucoma. And the positive predictors of post-traumatic glaucoma are angle pigmentation, and if the baseline IOP is raised, there's more chance, hyphema, and absence of cyclodialysis cleft. Then if the angle recession is more than 180 degrees, also lens injury.